Welcome back to the deep dive. We're looking at what feels like a truly pivotal moment in oncology today.
It really is. I mean,
Yeah.
we don't say that lightly.
No, definitely not, because it's rare that we get to see a single clinical trial potentially rewrite the rule book, especially for how we treat one of the most common and aggressive forms of breast cancer. But the paper we're analyzing today, which was published in the New England Journal of Medicine this February 2026, it does exactly that.
Yeah, it's a landmark study. We often see these sort of incremental gains in cancer research, a few percentage points here, maybe a slightly better side effect profile there. But this data is, well, it's substantial.
It's massive, right?
We're looking at a head-to-head comparison between the current gold standard of care and a new therapeutic agent, one that's already been making waves in the metastatic setting and is now moving into the early stage setting.
And we're talking about the Destiny Breast 05 Phase 3 trial. And the headline here is just pretty staggering. We're seeing a risk reduction that you simply don't typically see in large-scale trials comparing two active drugs.
Exactly. Two very active drugs.
Right. But before we get to those numbers, because they are impressive and we will get there, we really need to frame exactly who this trial is for. Because, breast cancer is a massive category.
Yeah.
And this is targeting a very specific, very high-risk group.
Context is everything here. This study focuses specifically on patients with HER2-positive early breast cancer.
Okay, HER2-positive.
Yes. And biologically speaking, HER2-positive cancer is known to be aggressive. It tends to grow faster and spread more readily than HER2-negative cancers if it's left untreated. But the good news is we've had great targeted therapies for it for a while now.
Right, but the patients in this specific study, they have a particular history. They didn't just get diagnosed and then go straight to surgery.
Well, they went through what's called neoadjuvant therapy first.
Neoadjuvant, meaning before the main event, the surgery.
Precisely. Neoadjuvant therapy is a standard approach for these tumors. You give the patient chemotherapy and targeted antibodies before the surgeon even goes in.
Trying to shrink it down.
Trying to melt the tumor away completely, actually. Ideally, when the surgeon removes the tissue later, they find what we call a pathological complete response.
Meaning no cancer cells are left at all.
Exactly. It means the drugs did the job completely.
But for the 1,635 patients in this Destiny Breast 05 trial, that didn't happen.
And that is the critical distinction for you to keep in mind here. These patients had residual invasive disease.
They took the best drugs we had up front, went through the surgery, and the pathologist still found viable cancer cells.
Right, which places them in a really high-risk category. Their cancer has effectively proven that it can survive the first line of defense. So the risk of recurrence, the cancer coming back, potentially in the brain or liver or the lungs, is significantly elevated compared to someone who had that complete response.
Wow. So the clinical question then becomes, what do we do now? We've used the standard chemo. The cancer is still there. We need a cleanup crew.
A cleanup crew is a great way to put it. We need a consolidation therapy to wipe out that microscopic disease and prevent the recurrence.
And historically, or I guess I should say currently, the standard of care for this exact situation has been a drug called Trastuzumab emtansine.
Right. Widely known as T-DM1.
T-DM1. And it's an antibody-drug conjugate. Let's actually pause on that term for a second. Antibody-drug conjugate, or ADC. I always think of these as guided missiles.
That's a very solid analogy.
You have the antibody, which is the homing system finding the HER2 protein on the outside of the cancer cell, and then you have the payload, the chemotherapy, basically strapped to it.
Exactly. And T-DM1 has been the defender in this space. It's effective. It replaced standard Herceptin years ago because it was simply better at controlling this residual disease. But now we have a new generation of ADC entering the arena.
Trastuzumab Deruxtecan.
Or T-DXd.
T-DXd. So this is the big matchup the trial is comparing. The established champion T-DM1 versus the newcomer T-DXd. Now, I noted in the study design that the dosages here were quite specific. T-DXd was given at 5.4 milligrams per kilogram, whereas T-DM1 was given at 3.6 milligrams per kilogram. Why the difference?
The dosage difference is interesting, but it largely comes down to the pharmacokinetics and the tolerability of the specific payloads. The chemotoxins attached to the antibodies. T-DXd carries a completely different type of chemotherapy agent than T-DM1.
Oh, really?
Yes, and it actually carries more of it per antibody. It has a higher drug-to-antibody ratio. So at that 5.4 milligrams per kilogram days, you are delivering a very potent punch.
And I guess the question this trial asked was, is that heavier punch worth it? Does it actually translate to better survival for the patient?
That's the billion-dollar question.
And they set this up as a massive, open-label, randomized trial. roughly 800 patients in each group, randomly assigned 1-to-1. When you see a sample size of 1,635 patients, that gives you a lot of statistical confidence, doesn't it?
Yeah.
I mean, this isn't some small pilot study where a few lucky patients could skew the data.
Absolutely not. A trial of this size is designed to be definitive. They're looking for a clear, undeniable signal. And the primary endpoint they chose was invasive disease-free survival, or IDFS.
Which is pretty much the gold standard metric in this setting.
It is. It measures the time from randomization until the cancer comes back invasively or the patient dies from any cause. They essentially started the clock and watched to see which group stayed cancer-free longer.
And this is where we get to the data that basically has everyone in oncology talking right now. The hazard ratio. I mean, I've seen hazard ratios of 0.8 or 0.75 celebrated as major practice-changing breakthroughs. But this paper, it reports a hazard ratio of 0.47.
Yeah, it is a number that literally stops you in your tracks.
For the listener who maybe doesn't spend their day looking at oncology statistics, let's just break down the sheer magnitude of a 0.47 hazard ratio.
Right, so in plain English, a hazard ratio of 1.0 means the two drugs are exactly equal. There's no difference. A hazard ratio of 0.5 would mean the new drug cuts the risk of the event, the recurrence or death, by exactly 50%.
And this was 0.47.
Exactly. So T-DXd reduced the risk of invasive disease recurrence or death by 53% compared to TDM1.
That is massive. And we have to remember, we aren't talking about comparing this new drug to a placebo group here. We are comparing it against TDM1, which is a very active, highly effective drug. To outperform the current champion by more than 50% is, well, it's almost unheard of in a phase 3 trial like this.
It really is. It implies a fundamental shift in efficacy. It suggests that T-DXd isn't just, a little better. It is biologically superior at hunting down and killing these resistant HER2-positive cells.
Let's look at the absolute numbers, though, because I think percentages can sometimes hide the real human impact. At the 3-year mark, so 36 months after starting treatment, what did the actual survival rates look like?
So at the median follow-up, which was 30 months, they projected out the 3-year rates. In the TDM1 group, the current standard 83.7% of women were alive and free of invasive disease, which honestly is a respectable number given how high risk these patients are.
But the T-DXd group?
A T-DXd group was at 92.4%.
Wow. So roughly a 9% absolute difference. That means for every 100 women treated, about 9 more are completely cancer-free at 3 years if they took the newcomer T-DXd instead of the standard TDM1.
Yeah. And when you reverse that and look at the events, the treatment failures, it becomes even starker. In the T-DXd group, only 51 patients, which is 6.2%, experienced an event.
And in the TDM1 group?
It was exactly double, 102 patients. 12.5%. The number of recurrences was literally cut in half.
That just feels like a definitive mic drop on the efficacy front. I mean, if you're a patient looking at those charts with your doctor, the choice seems completely obvious. You want the drug that gives you a 92% chance of being cancer-free versus 83%.
You do. And if efficacy were the only metric we cared about, our discussion would end right here. TDX would replace TDM1 overnight, and we'd all move on. But as you know, clinical medicine involves treating a whole human being, not just a tumor. And this is where the New England Journal of Medicine paper abruptly shifts gears.
The safety profile.
Yes.
This is the trade-off. Because when we look at the side effects, these two drugs behave very differently in the body.
They do, and this is absolutely crucial for patients to understand. TDM1, the older drug, has a toxicity profile that is actually largely asymptomatic for the patient on a day-to-day basis.
What do you mean by asymptomatic, like they don't feel it?
Exactly. We see things like thrombocytopenia, which is a drop in platelet counts in nearly half the patients. We see liver enzymes, AST and ALT, rising. But the patient doesn't usually walk around feeling their liver enzymes rising. They might feel completely fine, even if their blood work looks a bit concerning to the doctor.
Okay, so contrast that with T-DXd. What is the daily reality for a patient taking this new, highly effective drug?
It is much physically harder. The trial data shows a significant burden of gastrointestinal toxicity. Nausea was reported in 71.3% of patients on T-DXd.
Wait, 71%? That is the vast majority of people taking it.
Yes, and vomiting in 31%. Constipation in 32%. Fatigue is also a major factor. So while TDM1 might affect your lab results, TDX affects your lunch. It affects your ability to just get out of bed and feel normal.
That's a profound quality of life difference. I mean, if you're taking this drug for a year, which I believe is the standard duration, you're essentially signing up for a year where you're very likely to feel sick to your stomach.
And that requires a completely different approach from the oncologist. With TDM1, you're mostly just monitoring blood counts. But with T-DXd, you need aggressive, prophylactic anti-nausea protocols right out of the gate. You need to be managing diet, hydration, and comfort constantly. But, and this is the big part of weighty, but as uncomfortable as nausea is, it isn't usually life-threatening. The trial identified a much darker cloud hanging over T-DXd.
Right. Interstitial lung disease, or ILD. I definitely want to spend some real time here because this seems to be the one major red flag that could derail the success of this drug. What exactly is happening in the lungs with ILD?
So ILD is a condition where the drug basically triggers an inflammatory response in the lung tissue itself. It causes scarring and inflammation in the interstitium, which is the tissue and space around the air sacs of the lungs.
So it's not like an infection, it's the drug attacking the tissue.
Exactly. And this makes it very hard for oxygen to pass into the bloodstream. It usually starts as just a dry cough, maybe mild shortness of breath, but it can progress rapidly to severe respiratory failure.
And the data on this in the trial was incredibly lopsided.
Very lopsided. Adjudicated drug-related ILD occurred in just 1.6% of patients on TDM1. It's a known risk for that drug, but it's rare. On T-DXd, however, that rate jumped to 9.6%.
So roughly 1 in 10 patients developed lung disease caused by the cancer treatment itself.
Correct. And while most of those cases were low grade, meaning the patient recovered when the drug was stopped or when they were treated with steroids, it wasn't a zero risk for mortality. The study explicitly reports that 2 patients in the T-DXd group died specifically from ILD.
Wow. That is a heavy reality to sit with. You're curing the breast cancer, you're preventing a recurrence, but the treatment itself carries a small but very real risk of fatal lung injury.
It creates a deeply complex ethical and clinical calculation. With TDM1, we almost never really worried about the lungs. With T-DXd, pulmonology suddenly becomes a central part of the cancer care team. The study authors emphasize appropriate monitoring and management, and that isn't just standard boilerplate text. It's a serious warning.
It means you have to be vigilant.
Right. It means you need baseline CT scans. You need to educate the patient that a cough isn't just a cold, it's a medical emergency until proven otherwise.
I'm trying to put myself in the shoes of a patient hearing this. I have high-risk cancer. I know it might come back. I'm offered a drug that cuts that recurrence risk in half, that incredible 0.47 hazard ratio, but I have a 10% chance of lung injury and a 70% chance of severe nausea. How does a doctor even guide someone through that choice?
It usually comes down to the fear of the cancer versus the fear of the treatment. For high-risk HER2-positive disease, the fear of metastasis is incredibly high because metastatic breast cancer is currently treatable, but it's not curable. So most oncologists and patients are willing to accept the toxicity of T-DXd to prevent that ultimate outcome. The benefit that 9% absolute survival gain is generally considered worth the risk of ILD, provided the monitoring is strictly enforced.
So the strategy isn't to avoid the drug, but to respect the drug.
Precisely. You respect its potency. You lower the threshold for intervention. If a patient on T-DXd has even a grade 1 ILD, meaning just asymptomatic changes showing up on a CT scan, you might hold the drug immediately. You don't push through it like you might with other mild side effects.
You can't just tough it out.
No, absolutely not. The management guidelines are much stricter because the consequences are irreversible scarring or even death.
It seems like T-DXd is a very high-maintenance drug. It performs like a Ferrari, but it needs a pit crew checking the engine every single lap.
That is a very fair assessment. And we have to consider the duration, too. We're giving this for 14 cycles. That is a long time to remain perfectly vigilant.
Did the study show any other secondary outcomes that reinforce this whole decision? I know we talked about invasive disease, but what about other forms of recurrence?
They did look at overall disease-free survival, or DFS, which includes non-invasive recurrences like DCIS or second primary cancers, and the results mirrored the primary endpoint almost perfectly, 92.3% versus 83.5%.
So it's consistent.
Very consistent. This tells us the effect is robust. It's not just a statistical fluke in one specific area. The drug is systemically suppressing HER2-driven growth far better than TDM1.
I want to circle back to the dosage you mentioned earlier, the 5.4 milligrams per kilogram. Do we think the toxicity, especially that 9.6% ILD rate, is dose-dependent? Like, could they lower the dose to save the lungs, or would they just lose that amazing efficacy?
That is the million-dollar question for future research right now. In metastatic trials, they have played with dosages, and 5.4 seems to be the sweet spot for efficacy. If you go lower, you might lose that spectacular 0.47 hazard ratio. If you go higher, the toxicity becomes completely unmanageable. So right now, the package deal is this dosage. We accept the 9.6% ILD rate as the necessary cost of the 92.4% survival rate.
It's a package deal. You just can't uncouple the benefit from the risk yet.
Not with our current technology, no. Maybe in the future we'll find biomarkers that tell us exactly who is going to get the lung inflammation. If we could predict that, we could keep those specific susceptible patients on TDM1 and give everyone else T-DXd. But right now, we are flying completely blind on individual susceptibility.
So looking at the big picture of this trial, this is effectively a changing of the guard. TDM1 had a really good run, but TDX has taken the crown for this specific high-risk group.
Yes. The study concludes that among patients with residual invasive disease after neoadjuvant therapy, T-DXd resulted in significantly longer survival free of invasive disease. It is the new standard of care. Guidelines will change. Insurance approvals will follow. The workflow of clinics is going to have to adapt to the heavy monitoring requirements, but the drug is here to stay.
It's fascinating how medical progress works. We solve one huge problem, the cancer recurrence, and in doing so, we create a completely new challenge managing these complex systemic toxicities.
It's the paradox of modern oncology. Our weapons are getting sharper, but they cut deeper. TDM1 was a much cleaner drug in terms of how patients felt, but it left too much cancer behind. T-DXd cleans up the cancer, but it demands a heavy toll on the body.
For the patients listening or the family members navigating this, the takeaway here seems to be one of cautious optimism. The cautious part obviously being the lung monitoring, and the optimism being that incredible survival data.
I would actually say it's more than optimism, it's confidence. If you have residual disease, your anxiety about recurrence is very real. And this drug offers a statistical safety net that we simply didn't have before. Knowing that you have a 92% chance of being invasive disease-free at 3 years is a really powerful psychological anchor for a patient. It changes the whole narrative from waiting for the other shoe to drop to actively suppressing the disease.
But it definitely requires patient empowerment. You really can't be passive with a drug like T-DXd.
No. You have to report your symptoms. You have to be totally honest about how you feel. If you have shortness of breath, you don't minimize it or blame it on the stairs. You tell your oncologist immediately. The success of this drug absolutely depends on the partnership between the patient and the doctor. If that communication breaks down, the safety risks rise exponentially.
It's a true collaborative effort. The drug does the heavy lifting, but the human team has to steer the ship.
Exactly. And the team now includes the patient more than it ever has.
Before we wrap up today, I want to leave you with a thought about where this entire field is heading. Because we're seeing this pattern across oncology right now. Immunotherapies, ADCs, CRT cells, they were all incredibly effective, but they all introduced toxicities that just didn't exist in the era of plain old standard chemotherapy.
Right, we're seeing immune-related adverse events, cytokine storms, and now this interstitial lung disease.
It really makes me wonder if the future of cancer centers is going to look radically different. Right now, you go to a cancer center and you primarily see oncologists. But with drugs like T-DXd becoming the standard, are we going to start seeing pulmonologists, cardiologists, and gastroenterologists embedded directly into the oncology clinic?
We are actually already moving toward cardio-oncology as a dedicated subspecialty. Pulmo-oncology is very likely next. You just can't treat the cancer in a silo anymore.
If the cure for the cancer attacks the lungs, then the lung doctor is just as important as the cancer doctor. It's a fascinating evolution of the field. We are getting so good at killing the tumor that our main job is becoming protecting the host.
That really is the new frontier. Survivorship isn't just about being alive anymore. It's about preserving organ function, and your quality of life after the war is actually won.
A complex victory, but a victory nonetheless. The hazard ratio of 0.47 speaks for itself. T-DXd has arrived.
It has. And for thousands of women, that is very good news.
That's it for this deep dive into the DESTINY-Breast05 trial. Thanks for listening, and thanks for grappling with the complexity alongside us.
It was a pleasure.